Hi, Henry, and welcome back to episode 4 of Ars Cryptotica. How has your week been?
Busy, dedicated to building the portfolios for refinable launches. Put up about 10 works this week. Have met with our guest today and one of his peers from St. John Fisher College. And I suppose let's welcome our guest. So today, this is going to be a rather unique conversation. We're talking with John Kiweewa, university professor and therapist from St. John Fisher University. He also happens to be my therapist when I need one. And our work together has been fascinating, to say the least. It started in a very general or normative, therapist-patient relationship and grew to something quite special, working with him at the university over the last few years in many different contexts. And that relationship continues to grow. And so we have a new project that we've been talking about the past couple of weeks, and we're going to get into that more today. Let's get John Kiweewa into the conversation. Welcome, John. Thank you for joining us today.
Thank you for inviting me.
So maybe start by just giving us a little bit of your background.
Well, as I said, my name is John Kiweewa. I'm an associate professor at St. John Fisher College. I've been here for around 12 years now, started back in 2009. And I have pretty much a dual role of professor, but also I am practicing clinician in the field, in the community. I see clients or therapy clients. Prior to coming to St. John Fisher College, I've been in the United States for a little over 2 decades. So I came here around 2000 from Uganda, where I grew up. And so I came through Pennsylvania, University of Scranton, moved to Syracuse University, and then moved up here in Rochester, New York. And all through I've been, working to maintain one of my primary goals has always been to maintain my relationships with these multiple contexts, and that is Uganda and then here in the United States mainly. So I have almost made it a point every year to travel back to Uganda to do some work. And so I do run quite a number of workshops on crisis and trauma training. I do also, I'm a visiting professor at Makerere University, the major or main university in Uganda. And so while I'm there, I engage in quite a number of projects, teaching, trainings, research with other professors, supervision of students. And so I've maintained pretty much that work, and I find it very enriching for me. And so in particular, because Uganda for me, has offered a context that drew me into therapy or into counseling in a way that was unique, particularly growing up in a context that was pretty much dominated by war, civil war, and the trauma that comes from all that experiences. So as a child of, I like sometimes to refer to myself as a child of war in some way, and how I have navigated that, and how that has really drawn me to wanting to engage in the practices of healing around that. And so trauma is a very, very dear, area to me as I work with individuals. So, see, one of the things that really has drawn us together is this work around trauma. And I'm hoping that we'll probably, speak a little bit more about all that. But for now, I don't know if that's enough.
Oh no, thank you. That's fantastic. And I just to go back to, you mentioned trauma, working with therapists in projects and in Uganda. I know at one point you were explaining to me the severe lack of therapists and the ability to work with the population of Uganda, that there's a major sort of lack. Is that what you were saying?
Absolutely. So there is definitely a major lack, and I think it's a large problem or challenge that we've had as a society in Uganda, and that is mental health as a formal profession, as practiced within a formal profession, has been lacking in society. And so we've relied predominantly on a traditional means of healing, of really engaging those aspects that we find challenging as individuals and as communities. And so only recently, within probably, I would say, the last 15, 20 years, have we really started to look at therapy or counseling as a professional, from a professional point of view. And that was aided pretty much by the HIV/AIDS scourge. So you probably all aware, or the listeners will be aware of the time when Uganda in the 80s and 90s was the epicenter of the HIV/AIDS epidemic. And it so happened that I grew up in a district, it's called Rakai district, right in the central, but close at the border with Tanzania in the south. That was actually the epicenter of the epicenter, of HIV/AIDS. And so the suffering, of course, that came from all the grief and the losses and in the challenges really drew some folks in national and international organizations in terms of providing psychosocial support. Prior to that, it was predominant. If there was any need, anything, any challenges, the material approach was pretty much predominant. But HIV/AIDS started to draw people in and really thinking about ways to provide psychosocial support. So that's the world I grew up in. And in addition, so to HIV/AIDS, as HIV/AIDS is picking up, we are also as a country coming from a civil war that brought, of course, the current government into power. And so you come to mix all that. And more recently, we've tried to see the standardization and professionalization of counseling. And so for me, one of my role and one of the decisions, one of the aspects that really pushed me to move into seeking doctoral training in counselor education was to be able to train those individuals now who can provide these kinds of services. Rather than going for living individuals to go to the traditional medicine man, the traditional healer. Now we need to build a body of professionals who can approach people from a professional perspective.
And on that note, I was wondering if you could, because I think that most of the work that you and I have done personally together has been around trauma. As my listeners here know, that I'm a post-traumatic stress disorder sufferer. It was what brought me to you was a lack of focus on, my mental state at the time that we met. But I was wondering if you could give some background on trauma as, in sort of contextualized trauma, and maybe grow it out a little bit. Give us a picture of what trauma encompasses, how it might impact individuals. It's a very complex mental health, concern. And I think we should start a little bit there. If you could give us a little bit of information about trauma in general.
Yeah, I don't know how much I can provide because, as you said, it's a very complex experience. One that tends to be everything sometimes and tends to be nothing at times. And so as professionals, or even as ordinary people, the way we think about trauma, we tend to think as from an events perspective. So this has happened, or it must have left people traumatized. And trauma, in one way, is not just about the event; it's about the individual's experience of that event in some way. But also, trauma is not just psychological; it is biological. We are hardwired in many ways biologically to respond to stress, to respond to traumatic events and experiences in ways where we have to determine whether to fight, to flee, to freeze, and sometimes to approach, a perceived threat. And so that, and many of those processes are not rational processes in a way. We don't sit there and start to think about, oh, you know what, here is, I'm seeing a threat, let me react, I am going to react this way. That rational part of our brain sometimes comes in after the less rational or the non-rational. So the reptilian brain, what has been referred to as, has already, and the mammalian brain have already made the decisions, if you could call them those decisions, to act. So trauma in many ways, in therapy, what my experience has been in some way confused or neglected because of the many other ways it manifests itself. So traumatic experiences can manifest as depression. They can manifest as anxiety. They can manifest in many different ways. So the symptoms sometimes become the diagnosis from a clinical point of view. You know, that we can't say, oh, this is depression, and forget the underlying issue, what that depression may be a manifestation of. And so for me, if we're not careful, many times I see clients being misdiagnosed or underdiagnosed because I see symptoms of depression, but I'm not careful enough to seek to question or to say, what's underlying, what may this be manifesting? And of course, trauma experiences, unfortunately, tend to be shameful. So we tend to be ashamed of the way we react and we experience trauma, which makes it really very private in many ways. So a lot of individuals who have experienced trauma in my clinical practice very rarely come to you and say, oh, I have some trauma. Oh, I have experienced trauma. Very rarely do they come to you and say, I have experienced this specific trauma or this event that has caused trauma for me. So it's very, because there is a shame that is attached to that experience. And a part of it is because trauma really engages our primordial selves, those non-rational, or what some would call the emotional brain, part of our brain. And yet we've been told that who we are is tied to how we think and how well and how much we think. So we are rational. I am rational. I shouldn't be feeling this way, or I should be able to manage these feelings. Why should I? I'm a grown-up, person. I'm a grown-up man. I'm a grown-up woman. Why should I feel this way? Why is it that I can't stop crying, for instance? I should be able to stop myself. So we engage in that kind of, we are engaging the rational part of us. But what actually is really at the core of the issues we're experiencing is not rational. It's not rational because we've been designed, particularly the non-rational part of our brain, to really help us to survive. So, and our brains are really intended to do two primary purposes: the survival and the thrival, to survive and to thrive. And yet trauma really hits at the core of those two objectives, to survive and to thrive. And so by pushing us more towards survival. And so thrival becomes really, really difficult. and challenging for individuals. However smart intellectual we may be, it's hard for us to engage in thriving when our body are requiring us to survive.
Yes. And I think you hit right on something, the idea of shame and the reluctance to come forward in the therapy setting. From my own personal experience, it took me well over a decade to start to talk about the trauma itself. And I avoided discussion of the trauma. And it was really out of the, like you said, shame, and the idea that my apprehension was kind of rooted in the stigmas. And I think you should touch on a little bit about how stigma, societally speaking, how cultural stigma around mental health concern is really made it your job very difficult.
Because I think we and this not only just the Ugandan society or the United States, society here in the United States, there is a tendency to, we understand physical illness. We're very empiricists in a way. We see, we touch it, we feel it, we smell it, and that's it. So because a physical illness, a medical illness, the doctor can go and say, diagnose it specifically and identify it and isolate it and treat it. What's not seen, the psychological experiences become very, for many individuals or many people in society, that's not something we should be able to, we don't understand, therefore it doesn't exist. I can't see it, I can't touch it, I can't smell it, it doesn't exist. So if I come and I'm explaining that to someone, that I have some, psychological challenges, they don't see it, they can't experience, they can't smell it, it becomes really difficult for them to accept it. There is also this idea of strength. What's at the core of a strong person? And so mental health, and this is, again, speaks to the other aspects of culture, of how we construct, strength and who has power. So for instance, what does it mean to be a man? What it means to be a man, for instance, in Uganda, is that you are strong, you don't cry. You do not in many ways complain about, these issues that make you look weak. And so when mental health, for the most part, becomes very, very private, because others do not want to know it, and I don't want to, because they're going to see it and view it as weakness. And who wants to be viewed publicly in society as a weak person? Nobody. So mental health has been really the privacy of mental health, that we are suffering in darkness, we are suffering in the privacy of our homes, of our corners, really makes it even more debilitating for individuals. There is shame everywhere. In trainings, working with the students, one of the things that they will say when they go to work with, particularly those who work with the young people, even having a mental health diagnosis, there is so much shame, and there is so much shaming, not just the shame that the individual may experience, but the shaming. Society really speaking against about others who may be experiencing mental health issues, and really categorizing them and characterizing them as weak, as not being strong enough.
Interesting, because see, I think, and what's coming across very clearly to me is the importance of narrative in the public space, and I think that's where we're our work together in its infancy now still, I think, is really about it's a project about taking back the narrative and maybe reshaping the stigma to be something more supportive of the community at large. Both people that need to understand mental health and mental wellness, or lack thereof, like it needs to have context develop, dialogues need to develop. And I think one of the ways, most important ways that that's going to happen is going to be through the arts, whether the arts are visual or musical or dance, that the arts have a great role to play, an extensive role to play in expanding the idea of what is therapeutic, and also how do we educate a public at large. Well, I believe the visual arts reach into people's hearts. They sort of sensitize them to whatever the visual stimulus is. So, as we move forward in this conversation today and we start talking about the projects, I think that's something that I would love for you to touch on, this idea of narrative and who writes the narrative, who controls the narrative, and why that's important.
Absolutely, and I think you speak to one of the now more one of the ways in which we've come to see therapy or approach therapy in what you could call, theoretically, a postmodern world, so to speak. A world that doesn't just see one truth, but sees multiple truths as possible. And so in that world, narrative therapy has really come to take center stage. Narrative and art, and so to speak, has really been around for forever, since probably the start of humankind. So the symbols, the metaphors, have really always been used as a way of healing and restoring well-being. And so that really has been important. And one way, and doing so, not just privately, but publicly. And so the project you are really talking about, the exciting part about it, is how do we take these internal conversations, these conversations that society wants to push underground or beneath the carpet, how do we take those and bring them to the fore and bring them onto the public square? How does narrative or therapy become part of the dialogue within the public square? In other words, people really beginning to talk about, say, depression, or anxiety, or PTSD, or schizophrenia, whatever that may be. That's really, I think, an important part of how to deal with mental health.
Yeah, and again, going back to my own experience, the trauma really manifested in me in a kind of severe death anxiety, a lot of ideation on my own on my own mortality and ways of dying, and where I lost control was through this sort of anxiety and racing thoughts. And and ideation is very problematic because it's in its own way, it's unstoppable, or it feels unstoppable because it's sort of in control of you versus you being in control of your thoughts. And it's really scary. And when, like I said, my personal story, and in my background, it was a doctor's suggestion to find ways of looking outside myself at the troubled subject matters. It's so that those troubled subject matters, I wasn't ideating on them in the context of myself, which led me down the path to art, which then became a process of externalizing those subject matters. And in that sense became an externalization therapy. So I think, which I know is a concept that's well respected in your community. I was wondering if you could talk a little bit about externalization therapy and how art falls into that category.
Right. So externalization is one of the key, from a narrative point of view, narrative therapy point of view, is one of the techniques, they would call them techniques of actually doing therapy. And in a way, the concept is that, again, psychological challenges and troubles, whatever we may call them, tend to be private. And there is a tendency for us to keep everything in, or to keep that inside, rather than, and the more we actually keep stuff inside ourselves, the more troubling that becomes. And so in some way, think about it, that pressure cooker that, where pressure is building and building, and at some point that pressure will need an outlet. That pressure needs to go out. And so externalization really is that process in a way that allows or enables an individual to share with others, or even with self, that which is internal, to bring it forth. And so that is maybe done in many, many different ways. And for you, as I think you're describing, the art, engaging, the process of engaging in art, really, and I think for me, this was really fascinating when I remember the one time when you came to kind of have a conversation, a dialogue with students in my class, in my trauma class. And one of the things you did was to actually engage in a painting, an actual live painting. The students, at least in reflecting about it, what really they found fascinating and probably profound was not so much the product, what actually they saw at the end when you were done, but the way your body was engaging in that process. The sweating that was coming out, the breathing, sometimes the shaking, all that externalization of that energy itself, for them and for me as a therapist, probably was much more important than the actual product that came out of that entire process. So externalization, again, is critical in therapy, because we have very few windows into what's going on internally with anybody or any person, even with ourselves. And so art is one of those ways that allows us to externalize, to share pieces of our perceptions, pieces of our feelings and our thinking with the outside world, or with others, or with ourselves, in a way. And one of the things that about trauma, one of the things that trauma does is it negatively impacts our ability to articulate our experiences. And so becomes really challenging. Sometimes I've worked with individuals who have experienced severe trauma, and they're unable to tell you exactly, not exactly, but they're unable to share what that experience may be, or their experience of that event, because they have lost words, they cannot put it in words. And art facilitates the expression of what we may not be able to do verbally, in a verbal way. And so it's that externalization of even that we may not be able to put forth in words.
And to that point, we've talked about great length about this idea of prompts and how it can be used in therapeutic practice, and how visual art, in developing a catalog of visual prompts for therapists to use in practice, is something that prompt could help to pull out those bits and pieces of narrative that the therapist needs to gain access, or just like an on-ramp into, working with a patient. Would you say that's accurate?
Yes, absolutely. So the two originators, as far as, professionally we know, of art therapy in the United States, Margaret Naumburg and Edith Kramer, really kind of each came up with, an idea of Margaret describing art in therapy, and Edith describing it as art as therapy. So this idea of art in therapy and art as therapy really is key to what you're describing here, or you're talking about here, and that is the prompts. And so the way I see these prompts is that when I look at a piece of art, there may be pieces of that piece that resonate with me. But also there is also this, and that could be therapeutic. That could, for me, give me facility, can facilitate my ability to talk about and say, that's exactly what it is for me. I can be able to see my experience in what I see in the piece of art or expressed somewhere. But there is also this other part of it, where the prompt could be me as a client describing what my experience may be, my feelings of a particular challenge, for instance, let's say PTSD. And that art being captured then by an artist. And that may actually allow me or enable me to say, haha, someone actually is able to portray what it is that I can only experience. And that's really critical in therapy. Because at the end of the day, whatever it is, it's about creating that dialogue, that it enables the client that I may be having to have a dialogue with self, with me as a therapist. But it also may allow me as a therapist to actually have a dialogue with this client. And that dialogue may be difficult for me to have that dialogue just, through talk therapy. So this becomes really, really important. It becomes almost a symbol and a metaphor, the way the project as I can see it. And those can be really, and those have been really helpful within the healing professions.
Yes, exactly. And, I think also if you could expand a little bit on this idea of how this project and how, because in this age of social media as a platform and the way in which we can build an audience and reach a public and sort of grow the message, that at the forefront for me is, a sensitivity to the stigma of mental health. And, I think a lot about, for me, one of the great symbols of the mental health crisis anywhere is homelessness, because I feel like the homeless more often than not have sort of arrived at their, destabilized, dislocated place in life as a result of perhaps not finding help. They fell through the cracks, and it's like sort of the last place they can go is nowhere, and that's where they are. And I think all the time about how they're so invisible, and to me that's just sort of like a metaphor for mental health and wellness and lack thereof. It's a symbol of that in the world, that we kind of, as a society and societies all around the world, choose to ignore mental health concern and mental health dynamics. And that is at the root of the challenge. And so because this project has the ability to be completely sort of publicized and grown outward across society, that's exciting to me, because I think taking back the stigma, sort of transforming, stigma into stimulation, to think and consider a different kind of dialogue around mental health. What do you think about that?
So I'm thinking in terms of so you touch on something really important that I think I mentioned a little earlier. One of the challenges is that mental health is invisible, and because mental health challenges are invisible, and because they are invisible, we can walk around and pretend the rest of us can pretend and walk around like it doesn't exist because we don't see it. And so making the invisible visible is really important. If you asked me, one of the ways that I see this kind of, I envision this kind of project, for instance, operating, is think about a night of a basketball NBA game where I see superstar, LeBron James wearing, let's say, a T-shirt with art, artwork that speaks to, say, suicide, with some, a symbolism of suicide. That's a public statement. When I see someone, for instance, moving around with a T-shirt with Black Lives Matter, that's making visible what probably someone is feeling, and that is my invisibility. That as a Black person, I'm invisible, and here is a public statement that says, oh, your life actually matters. So this is the way where I see PTSD matters. Oh, as a person who suffers PTSD, this may be my capturing a little bit of piece of my experience. That's really, for me, important. I can see lots of organizations active. So May, we are in a month, here in the United States, it's called Mental Health Awareness Month. And so different organizations are now engaging in different campaigns to make mental health, an issue. So to bring society to be aware of mental health. For me, this is one of those visible ways in which mental health can become, we can become visible, and we can become aware of it. We are in a period, particularly now in a pandemic, and I speak to a number of therapists here. We've never seen the numbers of people who are seeking for professional services. They have never seen the number. We've never seen this. And part of it is the success, if I could say, call it, of the campaigns over these years that have really attempted to make mental health visible within society, to make society become aware of mental health, of the challenges, of the need to actually even work on our own mental health, of the ways in which mental health can debilit it, can get in the way of people being productive or being able to pursue their dreams and goals. And so this, for me, would be one of those mechanisms that really allows, and you say something really important, to stimulate, because it's important to stimulate conversations and dialogue. It's not just enough for someone to send a message. I could see a message and I become indifferent. I could just say, oh, okay. But I think it's important, as you say, to stimulate that conversation. And one of the things that when I've shared some of the pieces that, we've already started working on with other, colleagues, one of the things that is really fascinating there in terms of their response is how it stimulates their thinking, or it stimulates their senses. They're able to say, wow, I see this, I can say this. And it's not just that they can see it all at once, but there are bits and pieces they see here and there. And that's stimulating that conversation.
It is. And something that's important too, we have to keep in mind, art historically speaking, where the advantage that especially the visual arts have is they have the kind of poetic license to tackle uncomfortable subject matters in ways in which, the space of mental health and awareness and growing these conversations and dialogues and stimulating those dialogues, it requires that poetic license to delve into symbolism and to delve into like the sort of, you know, morphology of symptoms. And, you know, when we talk about the narrative prompts where a patient can provide a prompt, or a therapist can provide a prompt for an artist, if we take that narrative prompt, which might be, you know, metaphorical unto itself, because they're speaking, you know, in ways like, I feel like I'm trapped in a box, you know, something as simple as that. Well, an artist can then interpret, I feel like I'm trapped in a box, and run with it. And so I think it's important to accept that the transition of galvanizing public awareness and transforming, you know, the negatives into positives is not going to be a comfortable process, but it's a necessary one.
Yeah. And one of the really important aspects of art, particularly in the way we are working in it, is having no predetermined interpretations of that piece. And it's very important for the artist, as you say, to not be forced to have a predetermined interpretation. At the same, on the other side, it's also really important for me, for instance, as a therapist, not to force a client into a predetermined perception. So this is the way I want you to see this piece. It's really important to have that license on either way. And I remember this was, for me, a really major aspect of our work together when we started. You know, the poetry, the writings that you did. And I remember you bringing those writings in the session and actually saying, could you read? And it was very, very important for me as a therapist, very intentionally, not to offer any interpretations of what I was hearing, what you wrote, but just to bear witness to you, and whichever way you wanted me to hear it, to bear witness to that process. That was for me a very sacred process, if I could call it, for you. And it was very important for me to keep it that way, that it remains your process. And so whichever way you chose to see it, or to read it, or to hear it, that was important. And so that's what I see with this, you know, kind of extending this piece, that the client or the individual has the license. One of the ways in which I like this, so when we were thinking about this kind of work, how do we structure this kind of the prompts, particularly, that will allow you as an artist to develop these pieces? I went back and forth, and one of those was, okay, we have the Diagnostic and Statistical Manual of Mental Disorders, the DSM-5, or which, you know, happens to be the book in psychiatry. And we already have definitions of these disorders. So, you know, we have the criteria, and how do you come to diagnose depression, PTSD, anxiety, and all that. So that's a definition. And that's very appealing to say, oh yeah, we have here, this is the standard definition, let's go with that and pull it out of the book, give them to the artist, and have the artist then develop it. But that's mental health disorders as defined. And I don't like the word disorders, because sometimes mental health actually can become a source of, the challenges can be a source of creation. As a trauma and a crisis person, I always think, I'm reminded that there is always opportunity in a crisis. So it's not always, you know, something that needs to be cured and dealt with, and, you know, but anyway, that's the conversation probably for another day. But the issue here for me was, how do we get the client or the individual, the prompts that represent these mental health challenges as lived experiences, not as defined by the professional, but as a lived experience. That for me was really is important. It's the core of this. So the prompts themselves are as people have lived these challenges. If I were to walk a day or to take a picture on one day of your life as you live with, for instance, post-traumatic stress, what may I capture? What may I see? What would that look like? If you were to explain it to someone who has absolutely no clue about what you're going through, what would that be? Because as much as we have these standard or standardized definitions or criteria, each individual actually experiences these aspects uniquely. There's no one homogeneous way of experiencing these mental health challenges. There's no one homogeneous way or path to healing. And so the art really has to be able to reflect those multiple ways of healing, the uniqueness of an individual. It doesn't mean that if it's my unique experience, it doesn't resonate with another person. So the piece of art that you produce may be one particular client's experience of, say, anxiety, but that doesn't mean that other people may not resonate with that piece of art. It's very possible that they will.
Yes, and you said something profound and important, which is bear witness. And in the same way that you bared witness to my process in the office, this project is about allowing artists a moment to bear witness, and to bear witness, and by witness I mean to identify, to interpret, to articulate, and to translate, and sort of put back into the world. And as I see it as an artist, if I sit with somebody's narrative prompt intended for me to think about, that is engaging in a moment of dialogue with that person's life experience. And it reminds me of Martin Buber and the sort of Buberian philosophy of in the between of, versus like that there's a space between myself and your patient, and that prompt is in the between of those of he and I, or she and I. And when one engages in dialogue, one has to be present and focus on the between. And if the more profoundly and the more intensely we focus on what is there, with all of our sincerity and compassion and love, the more profound that the start of that dialogue will be. And I just think I want to just touch on again, bear witness. I say all the time, what is art? It is, essentially the intention made manifest to bear witness to our time and place. And, that is just sort of the macro, modus operandi here that we're working on in the micro, with each individual prompt, and determining or interpreting that into a work of art that can then be used to facilitate, further dialogues.
Absolutely. And, narrative therapists sometimes describe one of the primary roles of a therapist is as a fellow traveler. So I am traveling with you as a client on this journey. We aren't going on a trip, we're going on a journey, because trips tend to have very predetermined destinations, a lot is known before you set off. You know, my flight is at this time. I arrive here this time. These are the many times you know, a lot is predetermined with a trip. With a journey, very little is known, and so the healing, the joy is in the process, not the outcome itself. And so the art, you know, that I remember one of my students actually, when I shared this idea of these prompts, went to, you know, a group of teens that she's working with and said, "Oh, would like you, you know, to describe, capture some of the ways in which you experience the challenges that bring you here." And you know, some of those individuals in that group actually did provide the prompts that I provided you with, and it's so in reflecting and talking about that, you know, what my, you know, student did, she shared how profound that was for those participants or the teenagers to know that someone else is actually maybe interested in knowing and learning about what they are experiencing internally, what's going on within them or within their lives. And so sharing that piece, I can't wait to hear the feedback, the specific feedback about how that, you know, client or teen, whoever it may be, really experience the piece that came out of their prompt. But the bearing witness, and this is really important because bearing witness is public. Bearing witness requires us to move away from a private to the public, to declare. And so mental health, because again of what we've really talked about, the ways in which the more private it is, the more challenging it's going to be. And that's, so the more we find that those diagnoses or experiences that force people within to kind of go private, the more those are going to be, the more debilitating such challenges are going to be.
Yeah, and I think also that you know, you can look at the idea of, we talk about externalization. Now, I have a process that I consider an externalization therapy that produces what people would consider an art object. But that art object, in the context of our project, becomes a vicarious externalization moment for the patient or for the client, meaning that where somebody is in a prison of privacy because of their trauma or whatever their symptomatics are, that person, I believe, and you could speak more strongly to this, that person is going to probably be more comfortable talking about an external intuition about their internal space, which is what the art, the visual reference is. So now they're not talking about themselves. So if you're dealing with patients who are, again, trapped in a prison of privacy, they're not, at least on the surface, they're talking about something outside themselves, which is the whole point of externalization therapy, is to externalize, to get it outside of yourself, to focus on it outside of yourself, so that you are not by default internalizing everything. Would you say that's correct?
Yes, and again, I think we see externalization more profoundly as a distinct technique in narrative therapy. And so it becomes really important in terms of to understand the context of why externalization narrative therapy really is important. Because traditionally, in traditional mental health or psychiatry, the problem resides within the individual. And the individual comes to be defined as the problem. It's almost here is someone, PTSD, oh, someone is schizophrenic. I mean, I don't know if you've heard that said, but oh, the individual becomes synonymous with the problem. And that's a traditional, that's problematic because, you know, mental health disorders are now seen as identities representing individuals, or a schizophrenic, or you know, manic, or so all those narrative therapy comes to say that the individual is much more, there is much more the individual than this aspect that is going on. The individual is not the problem. The problem is the problem. So let's take the problem outside the individual, put it outside here, and we are better placed now to deal with it. If it's outside, if we can't deal with it. And in many ways, from a narrative point of view, they can actually personify the problem. And we begin to talk about the problem, say, the therapist and the client, talk about this problem as an external event, as for instance, as an oppressor that we can now begin to deal with externally. Because now it's no longer part of you, it's not part of your identity. And I've seen many clients come in, you know, and they have been, oh, I am this. Okay. And how did you come to be that? Oh, I've always been diagnosed with this, and my doctor has told me I am this. And I said, well, that I don't know how helpful that is for you. My approach is different. I would like to think that there is much more to you, the person that I'm seeing, than that problem. And so how do we begin to focus on this problem, take it out of your now assumed identity and put it outside here? So that's one of the really major innovations of narrative therapy. So the problem is no longer within the, you know, the same as the individual. It is outside the individual. And so we need to create this reframe of where the problem is. If I know I am not depression, then I can be able to probably deal with the depression as a problem, as a distinct problem that is outside me, that now we can begin to work on.
Yeah, and I think shattering that prison of privacy is the whole point of therapy. You know, what you just said, it's just, again, it just strikes me as profound, this idea that your identity is the problem, but it's not. And, you know, when we were just, when we met the other day, in that notion of vulnerability is, to me, I think something to think about, because it's powerful to realize that what somebody experiencing a mental, you know, with mental health concern is experiencing extreme sort of an extreme hyper-focused moment of a specific kind of vulnerability, right? That their vulnerability is being taken advantage of, you know, by biological processes, and they're not coping with how extreme their vulnerability is being exposed. And so I love this idea of how mental health, say, historically has cramped identity, has sort of limited identity, and that society at large has almost encouraged, you know, the medical model has almost encouraged the simplification of somebody's complex identity by classifying them in the context of their disorder versus, you know, their wealth, the wealth of their soul and their being, you know, shouldn't come into play because they have a category of symptoms stemming from, you know, something that's not necessarily them. Like you said, it's the problem, not them. That's fascinating to me. I think that's something I want to expand upon in a future conversation here.
Right. And so one of the things that, and for me, coming from a trauma perspective or informed perspective, One of the things as a therapist that I have to be very careful about when I'm working with an individual who has experienced trauma is not to re-traumatize them, one, but also not to create traumas that are probably even larger than what they're bringing in through by really creating almost perpetuating the trauma. So someone comes to me and they're struggling, and I'm going to say to them, you are schizophrenic. That's now becoming part of the identity. And wherever they go, and so there is this way in which we transmit, for instance, medical information. We share medical information with other professionals for continuity of care. And when I receive information from a previous provider that says put schizophrenia on top, it's likely to shape my view of this client. And that may influence, perpetuate some of that shame, some of the stigma that continues to really debilitate this individual. And so it's really important to be careful about the, how we provide labels and what labels we provide and how we negotiate and dialogue with our clients, for instance, or individuals regarding these issues. So I grew up in Uganda, in a country where mental health tends to be pretty much seen in terms of crazy. So there is almost no difference between a mental health challenge and being crazy. And you are crazy when you are throwing stones. I mean, think about someone who is experiencing psychotic breakdown and all that. That's a person who is experiencing mental health. So now when you begin to talk with individuals about, mental health counseling and maybe seeking counseling, it's like, that's for crazy people. Like, that's not something you do unless you're crazy. I am not crazy. Okay, and so who are you? Who is going to provide me with that kind of help? Well, there is a mental health counselor, or there is a psychologist here. Oh, well, if they're psychologists, are they there to read my mind? They can read my mind, can't they? And that it's like this, mystery around the psychologists, the role and what they can do, psychiatrists or the mental health professional, what they can do. But there is that shame of, because we've framed it as, you have a mental health, challenge, you are crazy. Only crazy people experience that. And that's where the kind of the conversation really needs to change. But also that's where narrative therapy, I think, becomes really central in reframing or reconfiguring the conversation or the dialogue.
Yeah, and in my own life experience, which well, I received diagnosis for bipolar disorder, narcissistic personality disorder, schizo. How did you say that? Schizoaffective
schizophrenia or schizoaffective disorder.
Yeah, schizoaffective disorder. And I can remember once, shortly after I got out of a hospitalization, I got pulled over because I was in a really bad state of mind, and I had turned left without using a blinker. And the police officer, and this is less than 3 weeks after getting out of the hospital, approached the car like I had just robbed a bank, because turns out he actually saw in a file attached to whatever records he was able to read, pulling up my license plate, that I had just gotten out of the hospital for mental health. And it's like, I'll never forget that, how ashamed I felt that the police officer had already read me and identified me as a potential issue because I had received mental health care. And and you see how the challenges that we face in all, at least in the United States, with police in their handling of what is essentially a mental health crisis unfolding in public, and it results in, you know, an unnecessary death. That has to be looked at and folded into, you know, this really complex, you know, really misfortunate societal view of people and their vulnerabilities in, you know, in the moment. So I just wanted to say that, and also, you know, I think this entire conversation today, just speaking to you, John, my producer, John, is another extension of the definition of what art is. And I want to ask you if you understand what I just said.
Yeah, it's been fascinating listening to you guys talk. Just to confirm my understanding, I'm really excited about the project. It seems like the benefits are multifold. You know, not only getting the dialogue going with patients or people who need help, but also reducing shame by, you know, if people feel that an artist created a work that they can identify with, maybe they have the same feelings. That's a way of reducing shame. Maybe it's a bit of a sidetrack, but maybe some people will be inspired to make their own art to express how they feel, if, you know, if they feel so inclined. I think also getting just a general dialogue going. If you put together a huge collection of works and it becomes well known, I think just people talking about it would reduce, you know, kind of unlearning the shame. And that was something interesting when I always knew that, you know, it was shameful to say you have a problem, or you're weak, or you're damaged goods, or, you know, no one brags about that. But when you were talking about it, I was thinking, yeah, well, where does that come from? Like kids, I work with kids, I teach English in Japan, and kids are generally pretty shameless, right? So I guess it's just through, you know, upbringing and society where we're taught to be, that it's a shameful thing, but in reality, it doesn't have to be, you know, the way people are educated. So it sounds very, very interesting. Well, one question, I don't know if we have time for it, but I was thinking about the Rorschach Inkblot prints. I guess they've been around for 100 years, and I think everybody knows those images. But I don't have much background with psychology. But did those evolve, or they just became famous? And then, you know, it's kind of the same wavelength, right? You're using an image which is, you know, has greater bandwidth than just some predefined adjectives to say you're happy or sad. Or do you have any comments about those Rorschach Inkblot prints?
I'm really not much, you know, background in the Rorschach, apart from taking a course in assessment. I really haven't used any of those, but I think part of it also goes to the art that we are talking about, the ability to identify images and the pictures as a way that tap into certain aspects of who we are, particularly our you know, a brain, the way we think. So that art taps into certain aspects of our brain, of our makeup. And so, and when it does, then in certain way it facilitates certain observations, it facilitates certain reactions, it facilitates certain ways of certain perceptions. And so that's pretty much for me, probably as much as I can speak about that.
And did you have any other follow-up questions for John?
It's confusing. I think that was all. Maybe you know, we're getting a bit late. I was wondering what the next steps might be, and then before we wrap up, maybe if John wants to share his Twitter, or if there's a way people can get in touch with him. I don't know if there's something on social media.
Honestly, I am in my late 40s, but I am acting like I'm 90 years old because I am not on Twitter. I think I am, but I rarely use it.
Okay.
I would just like to say thank you, John, for coming on the show today, for having this wonderful dialogue, really expanding on the ideas that we've been discussing in private and that John and I have been discussing publicly here on the show over the last couple of weeks. I think a lot of information today to help people process we'll process this conversation moving forward and how it's going to be valuable to the NFT project and the NFT space. We've run out of time today, but again, thank you, John, for being with us, and we'll see you again soon.
Thank you very much.
Thanks very much, John. Take care.